Honored to be here with all of you. I want to thank those of you around the globe for joining us. This is a pacing seminar that is put on by the World Society of Arrhythmias, and it aligns with the World Society of Arrhythmia goals of generating educational, scientific, and quality improvement opportunities for healthcare professionals and for patients so that we can improve healthcare everywhere. And that aligns also with our mission statement, which is to engage and to educate all of those who are involved in arrhythmia care. We all know that pacing is an important part of the electrophysiology package, and therefore we are honored and pleased to be able to put on this seminar. I would first of all like to thank our partners and our colleagues who have helped us to bring this forward. First of all, I'd like to thank Medtronic as the corporate sponsor. Without this partnership with industry, things such as this are more problematic. Second of all, I'd like to take off a hat and give a round of applause to Dr. Ali Otto, who is the president of the World Society of Arrhythmias. He's done an amazing job in coordinating and collaborating with everybody to make sure that this program comes forward in a beneficial and an important way. I would also like to thank our leads or our coordinators. We're doing this as a three-part seminar. Dr. Ashley Chin led the first part. Dr. Deepak Padmanabhan, was kind and is leading the second part. And we will have a third part that will be coming up, and I'll leave that open at this particular point. I'd also like to thank Magnum Opus. That is the group that is putting this together for us. Without the operational infrastructure, we wouldn't be able to get there. Now, we all know that pacing has taken an amazing step from the original days when it was just a simple lead that would keep people alive to becoming more downsized, to becoming more reliable, and to move not into just the, protection against death, but maximizing the quality of life with rate control, with chronotropic incompetence adjustment, with conduction system pacing, with treating of heart failure, etc. So it is certainly in a growing and an elaborating field, and we hope to be able to share some of that with you throughout these series. We also know that remote monitoring for follow-up has revolutionized how we deal with these patients and can actually streamline the delivery of care. In this session, we will be addressing the implantation considerations. We've broken this series into three components. The first is pre-procedure, looking at how you select patients and what are indications. And that particular series is online at the WSA website, and I would encourage all of you to look and to try to learn from that. We will have a number of sessions related to implantation, dealing with all of the subtleties therein. And we are aiming with this particular thing for those who may be in geographies where they don't have quite the resources that are available everywhere, so that all people, wherever you live and however you practice, can actually do an excellent job to render care to their patients. Our third part of this series is going to be the patient management. That is looking pre, intra, and post about minimizing complications and maximizing outcomes, and then looking at how you follow up these patients. Throughout this format, there will be presentations. We'll have an opportunity for discussion and Q&A, and I ask those of you who are on board not to be shy, but to send your questions in or to jump in when we ask you to do that. And we try to make them very, very practical. In addition to that, we're going to make them case-based. So it's not just pure and dry, but actually related to a particular case that probably aligns with those that you have seen. So at that particular introduction, I'd like to hand the session over to my good friend and my colleague, Dr. Deepak Padmanabhan from India, and he will introduce and moderate this session for us. Deepak, great to see you. Thank you for joining.
Thank you so much, Dr. Deering. It's indeed an honor to be able to participate on this August forum. And as mentioned by you, I'd like to thank Dr. Otto for this opportunity. Pacing remains a challenge all across the world, and safe implantation of a simple dual-chamber pacemaker is a life-saving technique. It doesn't necessarily need to be done by electrophysiologists across the world, but it definitely needs to be done by cardiologists. So, as regards our audience here, tuned to them and their requirements in all parts of this world where this webinar is reaching, I introduce Dr. Krishna Pothineni, and it gives me a great lot of pleasure to invite him to present his thoughts on how to implant a dual chamber pacemaker safely. He's a board certified fellowship trained cardiologist specializing in electrophysiology. He works with the Kansas City Heart Rhythm Institute at HCA Midwest Health in Kansas City and Overland Park and Manhattan KS, Kansas City. He's affiliated with the Midwest Health Network of hospitals located throughout the area. I've known him for a very long period of time, and it gives me great pleasure to invite him again on this forum, on this platform, to share with us his thoughts onto something that I feel is very, very basic and very important. Over to you, Krishna. Looking forward to hearing from you.
Thank you very much, Deepak. Thank you, Dr. Deering, Dr. Otto, Dr. Padmanabhan, for the kind invitation. I'm going to share my slides here. Can you confirm if you can see my slides? Perfect. So good morning, good afternoon, good evening, everybody, wherever you are in the world. We're going to talk about basics of pacemaker implantation, focusing primarily on obtaining safe venous access and optimal lead placement for a basic dual chamber pacing system. We are not going to discuss more advanced techniques like bi-V pacing or leadless pacing in this session, and focus really on how we implant a basic dual chamber pacemaker system safely. So the objectives of my discussion and the considerations we have during any pacemaker implant is: how do we obtain safe venous access? How do we place the lead in the appropriate position in the right atrium and the right ventricle? How does that change if you are implanting a pacemaker versus an ICD system? How do we test these leads and understand if the placement is optimal and if the lead is going to be durable in that position? How do we make sure that we close the pocket well and avoid long-term complications? And how do we manage the incision long-term? Because once these patients get pacemakers, it's often a lifetime cycle of managing these patients. And we'll touch on different aspects of these topics one by one. First and foremost, once you have decided that someone needs a dual chamber pacemaker system, the first important issue is to obtain safe venous access. As most of us know, the venous system anatomy comprises of different components of the veins that drain from the left upper extremity or the right upper extremity into the central venous circulation. So if you look at the anatomy from our medical school days, we have the brachial and cephalic veins that merge towards the axillary vein. The axillary vein is completely runs in the extrathoracic part, and then once it crosses the junction of the first rib and the clavicle, you enter the intrathoracic part of the venous system. But once the axillary vein becomes a subclavian vein, the subclavian vein has an extrathoracic component between the first and the second ribs, and an intrathoracic component that is more central to the first rib. And that becomes important to know because in the early days of pacemaker lead implantation, venous access was often obtained deep in the subclavian vein. And there are some issues with that access, which we'll discuss subsequently. And currently, we all know that extrathoracic access is very important to minimize the risk of pneumothorax, to minimize the risk of what is called the lead crush, when the leads have to traverse between the ligaments around the clavicle and the first rib, where they can get injured. And when you look at a venogram showing the same anatomy, you can actually delineate all these anatomical features on a good venogram fluoroscopic projection. Here you can see the same cephalic vein coming in here into the axillary vein. You can see the axillary vein, the extrathoracic part of the subclavian vein. And once you cross this first rib margin, you enter the intrathoracic part of the subclavian vein. And our goal is to get venous access somewhere in this region and never cross the medial border of the first rib so as to avoid pneumothorax. The cephalic vein cut down has been a traditional way of getting venous access for a very long time, and it's an excellent technique once you understand how it works and you can do it safely. Here is a surgical implant technique picture of how you can isolate the cephalic vein. Usually, the cephalic vein runs in the deltopectoral groove where the left shoulder meets the chest. And once you start dissecting plane by plane in this area, there's often a very prominent fat pad that tells you where the cephalic vein is going to be. And very carefully, when we dissect the fat pad, you can isolate the cephalic vein very nicely like this, and you can secure the proximal and the distal ends of the cephalic vein. And directly access it with direct visualization, so you know exactly where your needle is going, and you can use the same cephalic vein entry point to put multiple leads. There are some operators who put even BIV systems completely through a cephalic vein approach because the vein is very pliable and flexible and can accommodate a large number of leads once we get safe access. The advantage of obtaining cephalic vein cut down is that everything is under direct visualization. You're very lateral in the deltopectoral groove, and there is almost a zero risk of pneumothorax because you're completely extrathoracic and your needle entry point is directly under visualization. If you look at this cartoon here, you can see that cephalic vein cut down is represented by the scalpel, where you can see a small cut being made in the cephalic vein. And you can see that there's nowhere close to the rib cage. It's very far away as you can get to avoid a pneumothorax. As opposed to a subclavian vein puncture, where you have a direct needle going very close to that thoracic inlet, like we discussed. And now the more preferred approach is this axillary vein puncture, which we'll go over. So cephalic vein cut down, I would say, has been going down in frequency over time as we got more proficient at other approaches like axillary vein punctures. But it still remains a very, very important technique to learn because sometimes that's your only bailout to obtain safe venous access. The second way, when we move on from cephalic vein cut down to an axillary vein puncture, the concept of understanding the venogram and knowing your anatomical targets becomes very, very important. As we discussed earlier, the anatomical landmarks we need to really understand are where the clavicle is, where the first rib and the second ribs are, and then identify the extrathoracic portion of the subclavian or the axillary vein that you want to stick under fluoroscopic and venogram guidance. The traditional AP projection on fluoroscopy overlays the lung field with where the veins run. A new technique over the past several years has become more popular, where instead of a traditional AP view, if you do a caudal view, either in slight LAO caudal or an AP caudal view, you can actually separate the lung space from the venous space visually very well. And this almost eliminates the risk of a pneumothorax even with an axillary vein puncture technique. If you see here, you can see the lung border almost ending here, and you see where your axillary vein is. So instead of coming straight with your needle like this and going down vertically and risking potentially causing a pneumothorax, if you work in the caudal projection and understand and look at your fluoroscopic views in the caudal view, you can actually see where the lung margin is and try to stay as away from it as possible. And there have been 2 papers published on this technique, which shows zero risk of pneumothorax when a caudal projection is used. Nowadays, at least in the US, the most common way of obtaining venous access for device implant has been ultrasound guided. We all know that ultrasound guided access reduces the risk of vascular complications in all our ablation procedures that we do. And the same thing has transcended even to device implant procedures. When you put a linear ultrasound probe in the deltopectoral area, you can very easily identify the axillary artery and the axillary vein right next to each other. And when you apply a little bit of compression with the ultrasound probe, you can see the axillary vein getting compressed. And often patients have intravenous lines during these procedures. You can see air bubbles going through the vein very easily to identify where the vein is. And in this ultrasound live view, you can see that that's the axillary vein where it's basically being compressed by the ultrasound a little bit. And then you have the axillary artery right next to it here. And the more important part of the ultrasound view is that you can actually see the lung. The white line that's moving here is the pleura. And you can visually identify where the axillary vein is, how deep it is, and how deep would you go if you to hit the pleura. So you can visualize your needle tip coming down through the subcutaneous tissue right there. You can see it poking on the anterior wall of the vein. And then once you enter the vein, you feel the release and the vein expands. You can see the tip of the needle in the vein. And that's the best way to identify your needle tip going straight through the anterior wall of the vein without having to go through and through the posterior wall, which would increase the risk of hurting the pleura and causing a pneumothorax. So ultrasound guided access has been extremely important in our workflows to obtain safe venous access. We usually cover the probe with a sterile sleeve, and then everything is in a sterile field, and you can obtain access very easily that way. In some patients, the vein might be deeper. There is a lot of subcutaneous adipose tissue, which puts the vein much deeper than where it is in this video, for example. In those patients, you can even make a incision in the deltopectoral groove and use the ultrasound probe with a sterile sleeve in the pocket. So ultrasound in the pocket has also been a way of obtaining safe venous access with direct visualization of the vein. And the venogram, like we discussed earlier, becomes very important, especially when we are doing when we're doing cases in patients who already have pre-existing leads, when they come with a lead malfunction or needing a device upgrade. And you can see how a venogram can help us identify a complete venous occlusion here, where there's no way for us to get access and put a lead down unless we do something different, like an extraction to get the lead out. So, especially in patients in whom we are anticipating venous problems, like people who are on dialysis, who have had central venous lines in the past for a long time, patients on chemotherapy who have ports in place for a while, you always have to keep in mind the possibility of venous occlusion. And doing a good venogram up front to identify these occlusions can really change the site selection or our approach to device implantation. Once we get venous access, rule number one is to make sure that we are in the venous space. We can see with all the visualization techniques we have with ultrasound and other techniques, we know that we are going into the vein, but it is absolutely essential to make sure that we are not entering the arterial space inadvertently. There have been cases reported of leads being placed in the left-sided circulation by mistake, thinking it was in the venous space. This becomes more relevant in people who have heart failure and who have pulmonary hypertension, where venous pressures can be high. And even though you can visualize going through even though it looks like it could be in the venous space, it might be in the arterial space. Here's a chest x-ray of an inadvertent lead placement where you can see both leads are actually not crossing the spine. They're just coming from here, staying along the plane of the spine and coming leftward, which is an important clue. If your wire is going in this trajectory, that's an important clue that you're not in the venous space and you're in the arterial space, and that would be a major surgical complication. And so, how can we identify that our wire that we put in is going into the right space? And there are two very simple things we can do. One, when you advance your wire from the venous access side down, always make sure that the wire is going down to the IVC. If you show on fluoroscopy that the wire is going all the way down to the IVC, that is a 100% specific finding that you're in the venous space. There's no arterial communication that goes down this way. The second thing you can do is when your wire enters the right-sided circulation, look at the PVC morphologies you generate when the wire goes and tickles the ventricle. And you can identify if the PVC is a right bundle morphology or a left bundle morphology. If you see right bundle morphology PVCs when the wire goes down, that's a clue that you are probably in the left ventricle and not the right ventricle. And that's something that I pay attention to every single implant to make sure that I'm in the venous space, because that's a very simple technique that can avoid a major surgical complication for a simple dual chamber pacemaker. So once we have venous access in, the next step would be to put some sheets over these wires and then try to start putting our leads in. But if you don't get good venous access up front, that changes the entire trajectory of the procedure. So very, very important first step in obtaining safe venous access with the techniques that we described.
Hi, Krishna. I'm just going to interrupt you there
Sure.
because I think this is a very, very critical part of the entire case. And if I may dare say, probably what makes or breaks the case eventually. A lot of people have challenges putting in pacemakers because they're not confident of venous access in that space. And I think you gave a very nice little introduction and thought process onto how to approach this issue. Dr. Deering, do you have any questions you would like to ask Krishna at this point on venous access or anatomy?
Yes, thank you, Deepak. First of all, I would like to re-echo exactly what you said. You did a very nice job of, I think, identifying how one can successfully and accurately, with minimal complication, get access. And there are multiple ways in which we can get access. I think one of the issues is, ultrasound and dye imaging are ways to visualize, the anatomy. But sometimes in certain areas, and again, this is designed to deal with countries that may have limited opportunities. We don't have that, and many patients have renal failure. So how do you approach that in those individuals who, because of the absence of any imaging technique or because of intrinsic problems that may preclude your desire to use dye or other factors to maximize what you just described?
Yeah, that's a great point, Dr. Deering. I mean, we have all these tools at our disposal, but we have to use them sparingly based on the patient that's on the table. So, when we don't have ultrasound resources or patients, we cannot give them IV contrast because of kidney injury. Number one, cephalic vein cut down is a great tool in patients like that, where we can visualize the vein without requiring any contrast and get access. And we can also do a direct fluoroscopy guided axillary vein puncture without the need for contrast. The anatomy of where the axillary vein meets the first rib, the second rib, and the thoracic inlet is very constant in almost all patients. So once we understand the fluoroscopic anatomy of what we're looking at, you can often get a direct axillary vein puncture even without the use of contrast. But those would be my two techniques: is a direct fluoroscopic guided puncture or a cephalic vein cut down.
No, I think you're absolutely right. And I have relied on the fluoroscopic considerations because of the consistent anatomy. And I do think it is important to learn as a physician implanting these devices how to obtain cephalic vein access because it is an important, not just bailout, but opportunity many times. Deepak, I'll hand it back to you.
Thank you, Dr. Deering. Krishna, I just have a couple of questions for you. A variation. I mean, Dr. Deering, both of you mentioned a consistent anatomy. By consistent anatomy, we are assuming that subclavian axis or the subclavian vein goes into the brachiocephalic, goes into the SVC. How often have you encountered in your practice a left-sided SVC, and how do you tackle that?
Yeah, I think that's a great point, Deepak. So, what Dr. Padmanabhan is referring to is a left-sided SVC, where instead of the left subclavian draining into the right SVC, it directly drains into the coronary sinus and enters towards the left side of the heart. And that becomes a challenge when we start implanting pacemakers because your wire doesn't go through the normal trajectory that you expect. So one of the first clue that you get is, if I can use this X-ray image to show, once you get axillary venous access here, the wire would go down this way and come down here and enter the right atrium. And if the wire is going this way, that's your first clue that you're dealing with abnormal venous anatomy. And the incidence of that is low. It's been reported to occur in about 500 to 1 in 1,000 patients that we do these procedures. But for some reason, they come in waves. You have a week where you have 3 persistent left SVCs, and then you don't see them for a year. But that's a very important fluoroscopic picture to keep in mind, that if your wire doesn't cross the spine and it wants to take an acute turn and go down this way, that's the persistent left SVC. My approach, if somebody has a persistent left SVC, is to go and check if they have a right-sided SVC from the other side, because you'll save yourself a lot of time and trouble by putting an implant from the right side in that situation than trying to struggle putting a lead through the persistent left SVC.
Great, I would agree. And probably one of the reasons why, as you mentioned, a venogram is a very useful evaluation prior to doing an implantation, because I believe a lot of us eventually make the device generator pockets before we before we do the venogram. Doing the venogram ahead of time could identify this variation and therefore allow for corrective measures in case we are used to or want to.
Definitely. If I can add one point to that is, one other technique of doing this, let's say, like Dr. Deering mentioned, if a patient has contrast allergy, you don't want to use contrast, you can always get venous access to the skin before you even make an incision. And that way, you know that your wire is going in the right trajectory before you actually create a pocket. And that way of doing it has been very helpful in my personal practice.
How often do you use a micropuncture kit, and what would be your insights into using one, and how do you use it if you were to use it?
Yeah, micropuncture technique, the concept of using a very small bore needle to minimize the risk of inadvertent injury is it's a very useful tool. In the world of ultrasound with direct visualization, I'm not sure it adds much more value because you can actually see the needle tip going down visually. But if I'm doing a fluoroscopy guided, landmark guided puncture, I often use micropuncture. Otherwise, a standard Cook needle is pretty safe and easy to use.
I
Great.
agree with you, Krishna. That's often the way in which I do it as well. The other thing, and it's a very simple point, but most people are right-handed, but not every human being is. And oftentimes the labs are set up to access more easily from the left side. But I think it's very, very important, to make sure that you go to the non-dominant side for obvious reasons. And number two, for those people who have renal failure, understanding the status of their fistula. Is it viable? Is it going to need to be changed to the other side? Because those things can influence it as well. What are your thoughts in that direction?
Yeah, definitely. I mean, in patients with AV fistulas, we always want to avoid the side of the fistula just to minimize the risk of torrential bleeding that could happen when you access the venous system on that side. But it all comes down to patient selection. When we discuss that somebody needs a pacemaker, the next step is which side do we put it on? And a lot of factors come into play. The dominant side of the hand is something you want to avoid. Some people have complications with venous system on one side versus the other, like persistent left SVC, like we discussed. So all those factors are very important. And I personally avoid the sides of the fistulas unless there is absolutely no other way of pacing that patient.
Excellent. I would invite you to continue on with your talk. I think this was very informative.
Perfect. So now that we have safe venous access, our next step is to implant leads. And when we talk about leads, I want to focus on a standard dual chamber pacing system and then go on to a different variations. So a standard dual chamber pacing system has a right ventricular lead and a right atrial lead. So when we implant a right ventricular lead, the lead comes all the way down from the venous system down to the right atrium. And then we have to cross the tricuspid valve to enter the right ventricle. And there are a couple of ways we can cross the tricuspid valve. We have stylets that we use that we can preform and shape them to get us to the points we want to get to in the right ventricle. That is one way of a stylet-driven approach of putting a lead in the right ventricle. There is a second way where you can actually pull the stylet back a little bit so the tip of the lead is floppy and flexible, and you can actually advance it to make a big U to prolapse the lead into the right ventricle. There is some anecdotal data that if you prolapse the lead into the right ventricle, that can minimize the risk of tricuspid valve injury as you go through, because the tip of the lead is so flexible, it's almost like a noodle, and it can just penetrate through the easy space between the leaflets rather than going through a leaflet or through a cord. It's not a really hard recommendation to do it one way or the other. Lots of operators have their own preferences, but you can either use a stylet to get into the right ventricle or use the prolapse technique. And once you get into the right ventricle, the more important aspect is where do we put this lead? And rule of thumb is you never put leads on the RV free wall because the free wall of the right ventricle is very thin, and in some patients there are um, lots of intracavity structures there, but the space between those intracavity structures can be very thin, almost like paper thin, and can increase the risk of a perforation. So we always want to put leads on the septum. If you look at the short axis view on the MRI, you see that where the RV and the LV meet, you have this interventricular septum, and our ideal position for a lead is somewhere in the mid to low septum from the right ventricular side. So how do we confirm that we are on the septum? And that's where our fluoroscopic landmarks become very, very important. Whenever we implant a lead, we always want to check in the LAO, left anterior oblique projection, to make sure that the lead is pointing septally. But it's also important to identify that every lead that's pointing septally is not in a great spot. And the reason for that is because of the RV overhang that happens over the LV. So in this short axis view, you can see that this is your right ventricle, this is your left ventricle. If your lead comes right here on the mid or lower septum, it's very safe. The risk of perforation is very, very low. But if your lead falls down too much and you're pushing it more leftward, you might be in this inferior gutter of the right ventricle where the free wall and the septal walls of the right ventricle meet. And this is a very thin area that can increase the risk of perforation. So when you look at your fluoroscopic projections of how we put this lead, this is an LAO view and this is an RAO view. So in RAO, your lead is coming down this way. In your mind's eye, you can figure out where the apex of the RV is, where the mid RV chamber would be, where the outflow tract would be. If you put your lead anywhere in this mid RV chamber, you will be safe in an RAO projection. But before you actively fix the lead, you always have to go to an LAO projection and make sure it's not on the free wall and it's on the septum where it's pointing leftward. But this is a good mid-septal position of the lead, but if the same lead, let's say, is coming down this way, it is still pointing leftward, but it's pointing downward and more leftward, which puts us in this gutter, which is a higher risk for perforation area. So very important to have orthogonal fluoroscopic projection, understand where the lead is going in RAO to stay in the mid-RV chamber, understand and double check that you are in the septum on an LAO projection. Do not actively fix a lead unless you confirm two fluoroscopic views. That's very, very important. How do we position a right atrial lead then? So once we position our RV lead, we bring our right atrial lead. And again, RAO and LAO is your friend. And you always want to have a mental view of the right atrial anatomy when we put these leads. The areas that you can safely implant a right atrial lead are the base of the right atrial appendage, which is the most common site where we put it, or slightly also in the mid body, but you want to truly avoid being straight at the tip of the right atrial appendage. If that's not a viable option, you can always place a lead in the Bachman's bundle area, which is slightly higher on the septal aspect of the SVC, or you can even put it slightly lower on the interatrial septum. The one area in the right atrium you want to avoid is the true lateral wall of the right atrium. The lateral wall of the right atrium has a lot of pectinate muscle, and the wall between the pectinate muscles is again paper thin and can be a higher risk of perforation with the atrial leads. So once we position ourselves, we want to check in RAO, LAO. You want it to be facing you as much as possible in an RAO view. In an LAO view, you can be facing slightly leftward, because the left atrial appendage is going to be slightly leftward, but you don't want it facing straight leftward because that's when you're on the free wall and you can increase the risk of perforation. And once you position these leads, you can check passive numbers. That is, you can check how the local sensing is at that location even before you actually fix the lead. That way you can avoid multiple deployments of the lead and identify a spot that's going to be electrically good overall. So once you put these leads in my personal opinion, the biggest factor that you need to pay close attention to is current of injury. So once you have a lead in and you actually fix the screw of the lead and you connect it for testing, the first thing you can look at is, do I have a good bite at this site where I'm putting the lead? And the way you can look at that is when you look at the analyzer, you will see a big ST elevation kind of a pattern, which is called the current of injury, which is basically telling you that wherever you took a bite, you have local myocardial injury that's causing this ST elevation. And I want you to compare this to this. So here is a patient where you have a local electrogram from the site where you implanted the lead, but there is no elevation of the injury current here at all. Compared to this, where you have a large elevation with a long downslope of the tail end of the current wave. This is what you want to see when you implant leads in a good spot. Even though you may be getting perfect numbers for this lead in this spot, if the current of injury is not good, there's a very high chance this lead is going to dislodge. If I have a current of injury that looks like this, even if the sensing is slightly lower than what is expected, or if the threshold is pretty high in this location, that's still going to be a very good place to leave the lead, because as the current of injury subsides and the local tissue becomes more excitable, all the parameters, sensing, impedance, threshold, everything will get better. So my suggestion is that every lead that we put in, the first thing we check is, do we have a good current of injury? And if we don't have a good current of injury, it is very wise to move the lead at that time rather than accepting the numbers and not looking for a better current of injury. So once we fixate our leads, what are the things we look for? And the primary things we look for are, how is the local impedance, where when you paste the lead, you can get the local impedance value. How is the local sensing? Usually for atrial leads, you want a P wave anywhere more than 1 to 1.5 millivolts. Sometimes that's challenging to obtain in patients with a history of atrial fibrillation, but 1 to 1.5 is a good target to have. For RV leads, you want an R wave of at least 5 millivolts. Usually on the septum, it is often easy to identify sites that have at least greater than 5 millivolts. And when you do a capture threshold test, if you're anywhere less than 2 volts or 1.5 volts at zero point 0.4 to zero point 0.5 millisecond pulse width, usually that's a good spot to leave the lead in, as long as there is a good current of injury, like we discussed earlier. And once we implant these leads, there are a couple other technical issues that become very important. And one concept is the slack that we leave on a lead. Whenever we implant leads, as you can see here, this right atrial lead is coming down. You want to have a lot of slack on the lead, but not too much, but just enough slack to make sure that when the patient sits up or when the patient starts moving their left arm, that there is enough redundancy built in the system that the lead doesn't get pulled back, or which can happen and can lead to either a full dislodgement or a micro dislodgement. So it's very important that you leave enough slack. Usually for the RV lead, you want to have a little heel where the lead's crossing over to the right ventricle over the tricuspid valve. For the right atrial leads, you want to make a big J kind of a look here, and hook it up to where the right atrial appendage would be. And it's very important as we do these leads, especially for the atrial leads, to do what is called a tuck test. Here you can see a cinefluoroscopy of a lead implant, where once we put the lead in, you can see I'm pushing the lead down from here. And once it goes down by about 1 or 2 centimeters, I'm rapidly pulling the stylet back halfway, just to make sure that the tip of the lead stays where we put it in. And that tuck test becomes very important to make sure that we got a good bite and the lead's going to stay in that position. And once we confirm all these parameters, the next step would then be to remove the stylets from the leads and then secure the lead. Secure all the leads have suture sleeves on them, and it's very important to tie the suture sleeve to the pectoral muscle and the pectoral fascia area in a very good way so as to prevent the lead from coming back. Inappropriate tying of suture sleeves is a very important cause for lead migration, loss of slack, and also lead dislodgement. So most vendors have suture sleeves that have at least 3 or 4 grooves on them. It's important to at least tie 2 of them in a tight way to prevent the leads from coming back. And once we tie the suture sleeves, you always perform a tug test on the leads, just a gentle tug to make sure that the lead's not moving. Even if you deploy 3 sutures and the lead is still moving, you got to do more. It's very important to ensure that once we tie the suture sleeve, the lead is not moving back and forth, because if it's moving, when the patient moves, the lead's going to come back. And once we finish everything, we connect the pins to the generator of the device. Always ensure that you know which lead is going in which port of the generator. I'm sure Dr. Deering, Dr. Padmanabhan have seen cases where the leads are put in the inappropriate ports of a generator and patients have to go back in again for that. When we put these set screws, when we put these leads in the generator through the set screw, it is also important to make sure there's no air between the tip of the lead and the set screw. And that used to be a thing that was a problem in the past, where we had to de-air the header first before we put it in. I don't think nowadays it's such a big issue. And once we put it in, we put the generator back in the pocket and start closing the pocket. So That's the basic approach to implanting a basic right atrial and a right ventricular traditional lead. And things I would focus on very much here are current of injury is very, very crucial to ensure that you got a good bite. Leaving an appropriate amount of slack is very important for long-term health of the lead and to prevent dislodgements. Tying the suture sleeve down is a very, very crucial part.
That was very, very comprehensive. I'm sure if people are listening to the way you've described this, we surely shall get much lesser lead displacements and poor slacks on these leads. Because what seems like a very simple procedure can actually get complicated very fast. Dr. Deering, your thoughts on this part, doing the actual thing?
No, I thought it was very, very nicely put together. The two things that really stand out to me, which I think unfortunately are not done enough, is looking for the current of injury. I find that the sine qua non. And just like you said, even if I have marginal sensitivity or thresholds, I check them as I'm going towards the end of the case. And usually in my experience, if it's borderline, it usually is much better by the time you're closing. The secondary thing is the tug test. I actually think that is very, very important. Those are things that I think people don't pay as much attention to. They've got the lead in. Looks like it has decent slack in both arenas, but I've seen many times when I've done a tug test, I get dislodgement. Not many times, but I've seen it happen. And that's why I feel it is an important, consideration. So I think both of those things will optimize the likelihood of you having a successful long-term implant. Because we're not just trying to get in and out, but we're trying to have good sensing, good capture, and good viability downstream. Deepak, what are your thoughts?
I think in addition to the points that you just mentioned, one critical aspect is the number of turns that are done to deploy the lead. Most of the times, the leads are screw-in leads. And one of the very important things to know about a screw-in lead, which is a little bit counterintuitive, is the fact that either these screws are in or they are out. There is no gradual screwing in the traditional sense of the way that we think of. So most of the times in my experience, we've had the screw come out in 8 or 10 turns at the proximal end near the pocket for the screw to come out. Any further turns are actually turning the body of the lead and can lead to inadvertent perforations. That's what I have thought. And I've seen a lot of training also being given with respect to kind of, oh, the screw is not completely out. Why don't you give a couple of more turns? 14 turns, 15 turns. I just think that's asking for trouble. What are your thoughts on that, Krishna?
Yeah, I mean, you bring up a very important point of stylet management, I think, Deepak, because when we are putting this lead, when the leads have stylets in them, and you're trying to turn the terminal pin using the A-frame, and it's very important, number one, that every turn you are doing, the torque is getting transmitted all the way to the tip. And the way to do that is to make sure that the lead is straight and you're not curving the lead in your hand when you're trying to use the A-frame. The number of turns you do depends on the lead, and different vendors have different thresholds on how many you have to do before the screw comes out. One thing I have noticed is if you're doing about 8 to 10 turns on your A-frame and you don't see the screw coming out, instead of doing more turns, just jiggle the stylet back and forth. That will help you transmit the torque down, and often the screw just comes out instead of overturning the screw. I think that would be a good tip to have as well.
That's a glorious tip. I
One
have
other quickie. Oh, go ahead, please, Deepak. You go
no.
first.
Go ahead, Dr. Deering. Go for it.
No, one of the things that obviously is a complication is perforation. No matter how well you do it, we're all going to have those. And you described very nicely, ways to avoid it with the, septal location of the RV lead. But it's ideal if you can pick that up sooner. So what clues do you see when you're doing a case that make you say, gosh, I've got to be a little bit careful? And how do you assess that on the table, before you send them back to the recovery area and then you get called because they're hypotensive or having other problems?
Yeah, definitely. I mean, great point. So one is the fluoroscopic projection. Paying attention to fluoroscopy is very important. Two is reversal of current of injury. When you are assessing your current of injury, if you see that the current of injury instead of being positive is flipping backwards, it's reversing, that's a very good sign that you're probably going through and through to the myocardium. And you can test it on the table by also checking unipolar parameters on the lead. If you check the unipolar parameter where you connect the black connector pin to the lead and the red to the skin or the instrument, you will actually see reversal of pattern. Unipolar numbers look worse than bipolar numbers. That's a clue that the lead may have gone through and through. And you can test all those on the table and try to avoid that from happening.
That's an
Is it
excellent point, and that's where I think is very, very key. And I, use the unipolar, electrogram when I have concerns in that direction. And it's been very helpful.
Sure.
is it concerning, Krishna? Suppose you get one of these on the table. Do you immediately reposition? Do you think that they should pull the lead out, reattempt at a different location, or get prepared with an epicardial access just in case the patient crashes? How do you deal with it? Yes, great, you've diagnosed it. But
Right.
again, as I said, access is a challenge. The worry about perforation remains a challenge for many budding implanters. So, how do you react to this situation in the cath lab?
Yeah, so fortunately, in 90+% of people that we put these leads in, the RV is a low pressure chamber. So once, if you have a micro perforation or a true perforation acutely, 99% of the time when you pull the lead back and reposition it, everything will be fine. In patients with pulmonary hypertension, that may be different, where the pressures in the chamber are higher and you want to be prepared for an emergent pericardiocentesis. Acutely on the table, the approach would be to just pull it back, try to reposition it, and get to a safer location. If somebody had a perforation that's diagnosed late and they already have a moderate to large pericardial effusion from it, then the approach would be different. Then you want to be ready for emergent pericardiocentesis and before you pull the lead out. So acutely on the table, Deepak, I think it is very safe to just pull the lead back and reposition it acutely.
Very nice. Very nice. Dr. Deering, if you may permit, I think we'll have Krishna move on with the rest of his presentation on the third aspect, newer lead positions.
Agree.
Yeah, so as we mentioned at the beginning, pacing has taken a revolution, and nowadays we have moved on completely from traditional pacing to connection system pacing. So when we talk about connection system pacing, there is his bundle pacing and left bundle branch area pacing, and we have different catheters and tools that to designs to try to get our leads into these specific positions with the aim to engage the conduction system to try to provide a normal wavefront of biventricular activation when we pace somebody's heart to minimize the risk of pacing-induced cardiomyopathy. So I just want to focus a little bit, not too extensively, about the techniques of how we get to the left bundle branch area where we want to do most of our pacing nowadays. So as you can see here in the fluoroscopic position, we have a sheath. The difference between putting a conduction system pacing lead and the traditional one is almost all conduction system pacing leads we put are driven by a sheath. So you have a sheath that's preformed, any of the shapes that you choose, to get us on the RV septum and point more leftward to where the mid-septal area where the conduction system would be. And once we get the sheath there, we advance our lead there and try to position ourselves in RAO and LAO again, orthogonal views, to make sure we're pointing to about 2 o'clock in both RAO and LAO. And usually that gets us to where the level of the left bundle branch is, so we can penetrate from the RV side of the septum and almost enter the endocardial side of the LV side of the septum. And as you're positioning this lead and you're trying to advance the lead, here you can see the tip of my sheath. You can see the tip of the lead just on the RV side. And as I advance, you can see the sheath coming back a little bit and the lead penetrating through the septum, with the tip of the lead being on the left side of the interventricular septum. And the depth of that septum can vary depending on the patient's anatomy. Often you can shoot a little bit of contrast from the sheath, so you can see layering of contrast on the RV side of the septum, and you can see that the ring of your lead is on the RV side, the screw goes in, and the tip is on the LV side of the septum. In patients who have prosthetic valves, you can visually see the anatomy. You know exactly where the left bundle branch is going to be, and you can engage it. As we are penetrating the lead through the septum and going to engage the conduction system, there are very pathognomic signs of how the EKG would look. So every point you want to do unipolar pacing to see what the morphology specifically in lead V1 would look like. So in V1, when you're on the RV side of the septum, you have a nice W pattern initially with an impedance of about 500 in the 500 range. As you screw the lead in a little bit into the septum, you will start losing the W and you will start developing a terminal R prime in V1. This little positive deflection at the end of the QRS in V1 is a sign that you are penetrating through the membranous septum and entering the left side of the interventricular septum. And usually that correlates with a small increase in impedance as you go through the membranous septum. And then when you cross the membranous septum and go to the left side of the septum, you have a small drop in impedance. And when that happens, usually you find a more prominent terminal R wave in V1, which tells you that you're engaging the left side of the septum. Whether you're engaging the conduction system or not is something we have to look based on other criteria, but that's the way to get the lead across, paying attention to the changes in morphology in V1 when you pace in a unipolar configuration, and also paying attention to what the local impedance parameters are as you go across. At this point, if you continue to penetrate the lead more, you often will see a drop in impedance even further, less than 500 ohms. And usually, when the lead impedance goes less than 500 ohms, that's a clue that you have actually penetrated through the septum into the LV endocardium. And that's not what you want. You want the lead to kind of stop right here. If you look at the echo image, you can see the lead coming from the RV side to the LV side and stops right at the endocardial surface. You don't want it to penetrate into the LV endocardium. There's also a way you can map the local potentials, and often you can also identify good Purkinje left bundle branch potentials that can tell you that you're getting closer and you're in the conduction system as you go. And even in the era of conduction system pacing, over the past decade, we have completely moved away from his bundle pacing to left bundle branch area pacing. And there are several reasons for this. His bundle is a very focal target, whereas the left bundle branch area, you have a much wider target. So your zone where you can land the lead is much wider and you can have better success. We have learned that his bundle leads have higher thresholds during follow-up, often requiring a revision. And that problem is negated by just pushing the lead slightly more apical and inferior into the left bundle branch area, where thresholds are often very, very good. So another feature to keep in mind is as you penetrate the lead through the septum, as the lead goes through, the lead can trigger PVCs, and these PVCs give you a clue on where your lead's going to be. As you can see here, when I was on the RV side of the septum, there was this PVCs looking like a W pattern in V1. As I continue to penetrate more, I start having PVCs that have a terminal R prime. And that's usually a sign that you're in the right spot to leave the lead. And these PVCs are called fixation beats. As you're fixing the lead, and you have PVC morphologies that look like the pacing morphology you want, then that's a good clue that the lead is in the right place and you can stop and start testing your lead there. There are several criteria to confirm if you have capture of the conduction system or not. I don't want to belabor the points here, but the main thing you want is you want a terminal R wave in V1. You want to demonstrate some output dependent changes in paced morphology, which tells you that you may be alternating between selective or non-selective or septal capture versus conduction system capture. If you record a bundle branch potential, that's a very good clue that you're in the right spot. There is also this parameter called LVAT or LV activation time, where you measure from the onset of the stim to the peak of V5 or V6 right here, as I'm measuring here, where if that parameter is less than 80 milliseconds, that's a sign that the lateral part of the left ventricle is being activated pretty rapidly. That's a sign of conduction system capture as well. So if you have at least 3 out of 6 criteria for this, you can pretty much say that you're engaging the conduction system, and that gives us really, really beautiful ECGs. Often when you have a good conduction system paced lead, patients you often get called from telemetry that the pacemaker is not working because the EKG looks normal, and it looks normal because you're engaging the conduction system very, very well. And this is usually the kind of ECGs we see post conduction system pacing, where you have a very sharp deflection of in almost all the leads. You have a nice terminal R prime in lead V1. You have a short stim to peak in V5 and V6. Usually lead 2 has a small R wave, lead 3 is negative. That tells you are at the level of the conduction system. So conduction system pacing has really changed the way we approach pacing. Again, I just went over it very briefly for the sake of time, but this has a different approach of how we place leads. Complications wise, it's very safe because the sheets that we use are preformed and they get us onto the septum where we really want this lead to be, and it avoids inadvertent placement of leads on the free wall or in that inferior gutter of the right ventricle that we discussed.
Very nice, Krishna. I think this was a very step-by-step evaluation or discussion on how we can place a lead definitely within the septum, something that we were not sure of prior to this particular opportunity. My only question regarding this at this point in time, since we do have a couple of cases to go and we are kind of running short on time, is that what do you do in terms of slitting your sheath? Because that's the one step which is different in this technique compared to the routine right atrial and right ventricular lead placement techniques. How do you manage to slit the sheath comfortably? Any
Sure.
trips?
All sheets, like we discussed, all conduction system pacing leads go through sheets. And the way the sheets are designed is there's a valve at the back end of the sheet, and they come with specific tools you can use to slit the sheet. So the way to do that is to engage the slitting tool right at the valve and go forward with your dominant hand a little bit to try to break the seal of the valve. And once that is broken, you want to keep your dominant hand steady and do a backward slitting motion with the other hand while the right hand or your dominant hand remains very, very steady. And you want to watch fluoroscopy while doing this to make sure that the tip of the lead doesn't really move. The other important point to mention is most often the lead used for conduction system pacing worldwide is the 3830 lead, which is a lumenless lead, which means that there is no stylet in it. So with a lead not having a stylet, once you slit the sheath, it is very difficult to add more slack to it because the lead doesn't have any pushability. So you want to always make sure that you leave extra slack before you slit the sheath because it's always easy to pull the slack back than adding it forward. That would be one suggestion I have about leaving some extra slack for these leads.
Dr. Deering, any thoughts on this?
No, I think you did a great job on that. And in the interest of time, I would like us to move on. We do have a couple of cases, and I want to make sure that we get to them. Thank you, Krishna.
Perfect. So, even if we do everything correctly, there are some complications of a pacemaker implant that we always have to keep in mind. We went over some of these and how to avoid these: lead dislodgement, pneumothorax, lead perforation, and we discussed all these areas where we can improve techniques and avoid these complications. Even after we put the lead properly, it is very important. Hemostasis is extremely crucial to avoid pocket hematomas. Hematoma increases the risk of a device infection almost by an odds ratio of 25. So it's very, very important to make sure bleeding is under very good control. And then I want to go over a couple of cases highlighting a couple of these points. So my first case is an 83-year-old female patient who was admitted with syncope. On telemetry, she was found to have 6 to 8 second pauses, which correlated with an episode of syncope, and so she was referred for a pacemaker implant. She underwent a dual chamber pacemaker implant, which was uneventful, and then all the lead parameters were looking good. When we checked her on post-op day 1, she was complaining of some mild chest discomfort, and her oxygen saturation was a little on the lower side. So we decided to get a chest X-ray. And this is what the chest X-ray looks. She has some deformity of her spine. and you can see the leads are in an appropriate spot. You can see the tip of the right atrial lead here. The RV lead is actually a conduction system pacing lead in the septum. But what we see is a large right-sided pneumothorax. So the question is, if we implanted a lead on the left side and we access the axillary vein on the left side with an ultrasound-guided puncture, how did she develop a right-sided pneumothorax? So Dr. Deering and Dr. Padmanabhan, any thoughts on how a right-sided pneumothorax can happen?
Well, one of the concerns that I would have is with placement of the lead, did you actually cross, through the right atrial tissue into the lung and perforate the lung? It can happen. It doesn't happen commonly, but it's definitely a possibility.
Yeah, that was our thought too. I mean, if it was a left-sided pneumothorax, we would have thought it was an access-related complication. But like Dr. Deering mentioned, this is probably a lead-related complication happening with the right atrial lead, where we were slightly more lateral, where we were probably penetrated through the free wall in a tiny old frail lady and caused injury to the pleura that led to a pneumothorax. So we put in a chest tube to relieve the pneumothorax. We checked the lead parameters were all normal. Unipolar testing of the lead was also within normal limits. Would you revise the lead?
Yeah, I would be extremely, extremely scared, but yes, I would revise the lead. What do you think, Dr. Deering?
With a similar amount of trepidation, I would also go back and revise the lead with caution.
Yeah, I think we're all thinking on the same page. We did the same thing too. Well, once the pneumothorax resolved, we took her back, and all we did was dislodge the lead and put it slightly more septally in an LAO projection, and everything went well. So, something to keep in mind that pneumothorax is not just an access-related complication; it can also be a lead-related complication. And avoiding free wall of the right atrium becomes extremely crucial when we are to avoid complications like this.
When you went back in, by the way, to revise the lead position, did you actually do unipolar electrograms, or did you do anything else to, assess where you were?
We didn't do unipolar electrograms intraprocedurally. We checked the unipolar sensing and threshold just through the device before we took her back. At that time, it was looking okay, but I didn't check it intraprocedurally. So our concern, Dr. Deering, was this was probably a microperforation, not a real through and through perforation that went through.
Exactly. And in an old, frail lady like this with very, very friable, thin tissue, that's the most likely scenario.
Sure.
Two
Because it
questions.
doesn't look like she had a hemo component to it. It looked like it was a pure pneumo.
It was a pure pneumo, and even the CP angle here is free of any fluid. So, but that's a great thought. If it's a true perforation and is bleeding into the chest, that's a much more important complication to deal with.
So here is a question that I had. I mean, two of them before we kind of wind up this case. One, were you tempted to put in a tined lead the next time
Uh,
around? And
yes,
two, did you use an antibiotic pouch?
we were very tempted to put a tine lead, but we didn't. We used the same lead and just repositioned it. But that's a great thought, especially in a situation like this. We did not use an antibiotic pouch this time because we went in back pretty quickly. But for most of generator replacements or higher risk of infection, we use an antibiotic pouch. Yeah. So
Just a quick question along those lines, Krishna. You mentioned two situations in which you do use an antibiotic pouch. Do you limit it to those? Because what I find happens is that more and more people are using them routinely, and I think the utilization should be limited. How do you approach it, and how do you approach it, Deepak?
I fully agree, Dr. Deering, that utilization should be limited. My approach is for generated replacements, people who get extractions for infection and going for a reimplant, or people who have high risk clinical features like ESRD patients, diabetic patients on insulin, patients on immunosuppression therapy. Those are the ones I think of a device pouch mostly. I think it's a very important resource, and especially as this goes to the rest of the world, in countries without much resources, I think it's important to use it sparingly.
Deepak, is it available in India and in other countries easily, or is it problematic?
It is available. And I echo both your and Krishna's views on the relative selectivity of using these pouches. God forbid we start getting resistance. That is something that we really don't need. We don't want to do another trial to figure out that another antibiotic actually works. But yes, for this exact same indications that Krishna mentioned, we do use these pouches, and it's really difficult to say that it works or doesn't work. But as far as the rapid trial did, it did show significant benefit. So I think under the indications of the same, the pouches is used. One evolving way, though, as a last statement on this one, is maybe if you get an infection, just switch over to a leadless pacemaker.
Yeah, that's one more webinar for us to go over. So, second, I'll briefly do a quick second case. 78-year-old female admitted with complete heart block and dizziness, underwent a dual chamber pacemaker implantation, went very well. She actually got a conduction system pacing lead with very good left bundle branch capture data. Presented for a 6-month follow-up visit, and she was complaining of symptoms of edema, shortness of breath, and actually epistaxis. And on physical exam, she did have 3+ pitting edema. Her jugular veins were up to the level of her mandible, and she had a 2 out of 6 soft blowing systolic murmur almost throughout the precordium. Chest X-ray was within normal limits, no evidence of any pulmonary edema or fluid or pneumothorax or effusions. And device interrogation showed normal lead parameters. She was A-sense and V-paced 98% of the time. Her 20 DCG showed a very good narrow-paced QRS showing left bundle branch capture. So what are your thoughts? What should we do? What might be happening here?
Show me her echo. Show me her echo. Show me.
Sure. So echocardiogram is very important. I mean, one thing, if this patient didn't have a conduction system pacing lead and had a traditional RV pacing lead, whenever patients come with symptoms of heart failure, the first thing is this pacing-induced cardiomyopathy? But the risk of that developing with a good conduction system lead is very, very, very low. But we still got an echocardiogram to see what's happening. Her LV function was doing okay, but the main finding on the echo was this severe tricuspid regurgitation that she was having, which is making her right atrium enlarged and causing symptoms of right heart failure. And when we looked at, when we looked at what was the mechanism of the TR, as you can see here, it's a more eccentric jet that goes towards the septum and then kind of goes around the rest of the right atrium because of impingement of the septal leaflet of the tricuspid valve by the pacemaker lead going through. So in this patient, even though we did everything as well as we could to try to give her an optimal paced configuration in a setting of complete heart block, we made her heart failure worse by causing significant tricuspid regurgitation. So we brought her back to the lab. We removed the left bundle lead that we put in, and we put in a newer left bundle lead under this time under echo guidance, just to make sure that we're not going through the valve again and causing more TR. Fortunately, after 3 months of revising the lead, her TR became mild and the symptoms have completely resolved. So again, something to keep in mind, you could do everything right in the implant, but sometimes you have to deal with some issues like this, and having an eye out for them and thinking of these things becomes very important in long-term management. I think that's all I had. Thank you so much for having me. But any final thoughts, Deepak and Dr. Dhiren?
Deepak?
Uh, before I'm gonna take you up on your thank you offer, uh, quick question was regarding this. Would you have done an annuloplasty had the TR not recovered? Because this is a common problem, and as we go more and more into leads which have more bulk, coils, ICD leads, multiple leads, this is a really big problem. So what would have
Yeah, I
been
mean,
final way to go about it?
yeah, I mean, lead associated and lead induced tricuspid regurgitation are very, very important factors, especially in the world of transcatheter tricuspid valve therapies that we have right now. It becomes a very, very important issue. In this patient, particularly, if the TR did not improve with lead repositioning, we would have definitely considered some form of transcatheter therapy to try to improve our tricuspid valve anatomy. I think it's often an understudied or under-recognized cause of right heart failure. But it's also important to understand that not every TR is lead related. So lead induced versus lead associated are two different things. And we have to make, and imaging becomes very, very important to identify which patients should get an extraction first versus who should not.
Krishna, I think that's a very important point. And there's no perfect therapy here. I mean, one could consider, using a leadless pacer where you'd be less likely to have that problem. But then you run the risk of, RV pacing induced cardiomyopathy. You could use a left-sided pacing through the coronary sinus branches alternatively, and that's an option. But again, in a person who has complete heart block, and I don't know what her escape mechanism is, the threshold stability and the potential, for non-capture over time is going to be higher. So every particular approach has its benefit and has its risk. And it's putting all those things together and trying to make the right decision up front, but also, like you nicely said, being willing, able, and looking to see what might be going on downstream. I agree with you that we do not recognize TR as much as we should. And sometimes it's the patients who have underlying pulmonary hypertension at some level or RV systolic dysfunction in whom those things can be exacerbated. And it's not just a unidimensional problem, but a multifactorial one.
Absolutely brilliantly summarized on that particular problem. So let me summarize today's session by saying that Krishna basically absolutely stuck to what we wanted him to by presenting some absolute fundamental basics regarding anatomy, access, implantation of leads, and finally gave us two really unique scenarios where it was going back to proving why it was the way it was that led us to the solution, and not going by what they say is experience or is the most common reason and so on and so forth. Which again brings us back to the point that we really need to prove every step of the way what the mechanism of injury or disease or arrhythmia is prior to prescribing any treatment for it. Dr. Deering, would you like to kind of go through takeaway points for this session for our listeners here?
I think, Krishna, you did a great job in allowing those who are watching this video to understand all the points they have to do about understanding the anatomy up front and how they can approach access. Secondarily, positioning the leads effectively and making sure that long-term as well as short-term benefits are there. And then also with conduction system pacing, how you can make sure you get the lead in the right place. And lastly, with your cases, understand the complication. That's exactly what we're trying to do. And I think, what we hope will happen is this should serve as an excellent guide for those in whatever location they are, anywhere on the globe, to understand how they can improve their techniques to get better outcomes. All of these sessions will be available on the WSA website, and we would encourage everybody who is implanting to go ahead to watch and to learn. I learned an awful lot to become better, and I thank you, Krishna, for your sharing of the information, your thoughts, and your experience. Deepak, I'm going to let you close out as our moderator for this session.
Once again, thank you for that very succinct and very gracious summation of today's session, Dr. Deering. Krishna, once again, thank you so much for doing this. I echo Dr. Deering's thoughts at the beginning of the session, thanking Medtronic, thanking Magnum Opus, and not at the very least, Dr. Otto, for this opportunity under his leadership and guidance to start off and kick off this important session, second session of the Medtronic Pacing series. Thank you once again for being here, everyone, and we hope to catch you on the next sessions too. I hope you send us some questions even offline, although we didn't get too many of them today, so that we can answer them and keep the discussion going. Because only by collaborating and talking to each other can we improve outcomes for our patients.
Well said.
Thank you.
Thank you.
Thank you.
Thank you very much. Bye-bye.
Thanks, everybody. Good day.
Good day.